Okay, we'll continue with the trauma upper limb. Okay, am I audible?
Yes,
Am
sir.
I audible? Okay. So we are probably this is the last session of upper limb trauma. Okay. We have finished almost all major joints. Now we are focusing on hand, wrist and hand. Okay. So something about scaphoid fracture. Okay. Please remember, scaphoid fracture is the most common carpal bone fracture. You can see here, you can see a normal X-ray wherein a scaphoid, you should know the arrangement of the carpal bones. Okay.
Yes, sir.
Okay. See, this is a normal arrangement. SLTP. You know the mnemonic, isn't it?
It looks too pretty.
Yeah, very good. So, this is the scaphoid bone. It is boat shaped. It is on the lateral part. Remember one thing about scaphoid, it is the most common carpal bone fracture. Okay, there are certain important things about scaphoid and scaphoid fracture you should understand. This is one example of scaphoid fracture, right?
Yes,
You
sir.
can see a line there. And what is important is scaphoid is almost 100% intra-articular except for the scaphoid tuberosity. So what happens? Problem with the intra-articular bone or intracapsular bone is non-union. Just say for example, intracapsular neck of femur, talus neck, and scaphoid. These three bones, fractures in these three regions are very vulnerable or go for a non-union because they are intra-articular and synovial fluid has an inhibitory effect on fracture union. So we are today focusing only on scaphoid fracture. Scaphoid can get fractured at different levels. Focus on this. So scaphoid can fracture can happen at any levels. What is important is please remember there are of course different descriptions: scaphoid tuberosity, transverse fracture, horizontal oblique, or vertical. Okay, but what is most important about scaphoid is scaphoid fracture is known for notoriously going for non-union and avascular necrosis. These are the most common complications of scaphoid fracture. So what is the problem? Why it goes for non-union? As I said, it is mostly intracapsular. It is intra-articular. And why avascular necrosis? Because of its precarious blood supply. There's too complex a blood supply arrangement of a scaphoid. But remember one thing, it receives blood supply from distal to proximal.
Yes, sir.
It receives blood supply from distal to proximal. So whenever there is a fracture, there is a lack of blood supply for the proximal part. So you should remember why it is going for a fracture, avascular necrosis is it is typical arrangement of a blood supply, which is supplied from distal to proximal, which is unlikely, isn't it? Unlike in any other parts of the body, it is proximal to distal. But here the arrangement is distal to proximal. Okay.
Yes,
So
sir.
most common again scaphoid most common fracture in the scaphoid is scaphoid waist fracture. This is the example, scaphoid waist
Waste.
fracture. Okay, and what is the treatment? scaphoid fracture. Scaphoid, whenever we mention scaphoid fracture, we talk
Yes, sir.
generally about scaphoid waste of the scaphoid fracture. So if it is undisplaced, put the cast.
Yes, sir.
If it is displaced,
Herbert stove.
see any for that matter, orthopedics is very very simple. If it is undisplaced, you most of the places you apply cast or in distal part, not in hip or other regions, hip or shoulder, whatever. Distal portions of the bone limbs, if they are undisplaced, you apply plaster. But if it is displaced, what is the whole idea? You have to reduce it. You have to reduce it. Once you reduce it either by closed method or open method, you have to fix it. Okay, we'll come to that later. So, what is the history they come with? They come with a history of, again, you know very well, history of fall on
Yes,
outstretched hand. Okay,
yes, sir.
whenever they come with, there are certain typical characters about scaphoid fracture. Please remember this. The patient comes with a fall on outstretched hand, and they come with tenderness around the wrist. They do not come and tell you that they have pain in the anatomical snuff box, isn't it? They come and complain that there is a pain around the wrist. So what is typical of a scaphoid fracture is you elicit tenderness at the anatomical snuff.
Anatomical members.
You whenever see, one beauty about orthopedics is if you are following, you can imagine and visualize in your own parts of the body. That is a beauty, unlike general surgery or medicine or whatever. Okay, look at your own hand whenever we are describing certain parts of the body, so that you will remember very well. So anatomical snuff box, of course there are borders where laterally it is by this is laterally, isn't it? This is this tendon is EPL, extensor pollicis longus. Where it deviates at a small bony tubercle here. What is that bony tubercle? Shivanand, Lister's tubercle. Lister's tubercle. Extensor pollicis longus comes here and takes a turn here. And what is this? This part, the medial part of the snuff box is by two tendons, APL and EPB, abductor pollicis longus and extensor pollicis brevis. It is
Yes,
no, it is nothing very very complicated. It is very very simple. It is first compartment of the extensor tendon. There are six compartments. I will not get into that detail. Okay, but please remember this. So this is anatomical snuff box. There are many important parts, I mean importance about anatomical snuff box. One is this is an autonomous zone for anybody, quick, autonomous zone for radial nerve. If you test and there is a anesthesia or a paresthesia or hyposthesia in this part, you can easily say there is a problem with the radial nerve. And important thing about again anatomical snuff box is here you feel for the tenderness of a scaphoid bone fracture. Scaphoid bone fracture. Okay, so patient with history of trauma comes there and you elicit tenderness. You look for the X-ray and X-ray is normal. X-ray is normal. So, but you definitely whenever you feel it is a scaphoid, suspect a scaphoid bone fracture, ask them to come back after 2 weeks to look for a fracture which might be visible after 2 weeks. Okay, so one or two, we'll take one or two MCQs. Which of the following is not true regarding the fracture of the scaphoid? Quick.
Sir,
Hmm?
Option 4.
Yes?
sir, fourth option, sir.
Fourth option, yes. It is not malunion. Non-union is more
Or
common. Okay. Will not do we have to discuss the choices? It is no brainer. I have explained only now. Right. Most common site of a scaphoid fracture?
West.
Yeah,
Waste.
West. Very good. Others also should try and answer. I am not trying to. I mean, there is no much competition. You should attempt answering. You might be knowing. Who knows? You might not be able to want to answer it, but that will be a good interaction. Okay. In non-union of scaphoid, vascularized muscle pedicle graft is taken from. I'll come to the non-union part of a scaphoid bone little later, but you answer the try and attempt to answer this question. In non-union of scaphoid, you use vascularized muscle pedicle graft. Which muscle?
Extensor pollicis longus.
Yes?
Extensor pollicis longus.
No, wrong. Anybody?
Mm.
Okay, I'll tell you why. Extensor pollicis longus is a tendon.
Yes, sir.
We want a muscle belly which is vascularized. Don't go for the tendon. That's in that with that logic, the brachioradialis also fails. Tendon is apparently avascular structure. We want a vascular structure. Muscle belly is more vascular. So it is either pronator teres or pronator quadratus. Okay, what do you mean by vascularized muscle pedicle graft? You take the muscle along with a piece of the bone and put it at the non-union site. So where is pronator teres? Where is pronator teres attached to?
Mm.
Roshan, I did explain you people in a position of the forearm in a fracture both bones.
Yes,
Fracture
sir.
it. Pronator teres. Where it comes? In the middle part of the radius. Proximally it is supinator. Middle it is pronator teres. Distally it is pronator quadratus. Quadratus is quadrangle in shape.
Yes,
Pronator
sir.
is the function. Orthopedics is very very simple. Try and 50% by mnemonics and rest of the 50% the words are self-explanatory. So what you do, there is a picture shown here. Concentrate on this. There is a non-union of the scaphoid. They have put a screw. Remember this screw, very important. Herbert screw. Herbert screw.
Yes, sir.
Headless screw.
Headless. Headless.
Remember, please remember that. That's very essential. So they have put a screw here because there was a non-union. See the gap here. They have taken this is a pronator quadratus. They have taken the one part. They have elevated the pronator quadratus from the radius with a piece of bone and turned here. They have put here, and then they have put this. So non-union vascular muscle pedicle graft is taken from.
Pointer quadrant.
See, even if you don't know so much theory, you remember the anatomy very, very easy to answer this question. Okay, these two are tendons. Pronator teres is far away. We want something in Mumbai, and pronator teres is in Delhi. Okay,
Yes, sir.
right. So this is one more thing which is explaining. This is what I was mentioning. Pronator teres taken from here, this part of the bone with the teres, and you can visualize this picture. I mean, is the picture clear or too small to appreciate?
Sir, no
See,
problem, sir.
okay. See here, this part of the bone is taken from here and attached to the scaphoid bone. This one more important thing you see here, scaphoid as the remember this, okay? As the fracture goes more and more proximal, the union rate goes on reducing
Because of blood supply.
because of the blood supply. Okay, we need not explain much into that. So perilunate dislocation. Come on, let us try and answer this question. Then we'll touch upon the relevant theory. Today it might maybe 10 or 15 minutes little late. We'll finish off this one. Okay, we'll not keep anything pending for upper limb trauma. So perilunate dislocation. Lunate and carpal bones dislocate anteriorly. Lunate stays in place. Carpal bones dislocate. Lunate and carpal bones dislocate posteriorly. Lunate dislocates anteriorly, but carpal bones stay in place. See, when you read this, try and visualize this, and don't just read. Then, because it appears when you it appears as if you are looking at the stars in the sky. No, it's very simple. Lunate, imagine it is after scaphoid, scapholunate adjacent to that. So what is here? They are giving option. Lunate and carpal bones dislocate anteriorly or posteriorly. Yeah, pretty sure.
Second option, sir.
Yes. Who is this who answered? That's very good.
Second, sir,
Okay.
second.
Second, lunate stays in place. Carpal bones dislocate. So perilunate, what is around the lunate is dislocated. Means all the carpal bones are dislocated, lunate stays in place. This is very, very important. So these are some radiographs, some schematic diagram I will show you where you will never forget. Hope one or two of you will take orthopedics and join us in future. But please remember, if visualization will never make you forget anything what you have learned. Okay. See, normal radiograph of a wrist appears like this, where it is a radius. What I write on the screen, it is legible, or is there a lag somewhere?
No, sir.
Okay. See, this is radius. This is lunate, and this
Capital.
is capitate. Very good, very good. Capitate. Okay, all these three are in line. Okay, look at this. What has happened in a lunate dislocation? Lunate has dislocated anteriorly, but rest of the bones are aligned. What has happened in perilunate? Lunate stays attached with the radius, but surrounding capitate, other bones have dislocated dorsally. Look at this. Look at the relation of lunate and radius. It is normal. This is perilunate. Look at this. Lunate has gone away, not
Lunate
connected. Lunate dislocation. Now you can remember easily lunate and perilunate dislocation.
Yes, sir.
Yes, sir.
Okay. Okay, good. Okay, this lunate dislocation, there is one interesting spill T sign or spill cup sign. I don't know, it might appear in future MCQs, I'm not sure. Look at the shape of this lunate. It appears as if there is a tea which is being spilled from the cup. This is one of the signs. Fancy people can ask such question. Okay, anyway, this is perilunate dislocation, the same thing. Murphy's sign, I'll come to that later. Murphy's sign is, if you can remember, I will explain here only. Murphy's sign is the third, this is the third metacarpal. Huh? This is not second, don't forget thumb. Thumb is first. This is second, this is third. If this third metacarpal head comes in same level, That means there is a problem here in the carpal bones. That is Murphy's sign. Here it is a normal, means they are order one. I mean they are going on in a decreasing order. This Murphy's sign is negative. We'll come to that a little later. So patient presents with wrist trauma. On examination, he has sprained wrist. No evidence of fracture. Tenderness in anatomical snuff box indicate what? Quick. Imagine this. Don't just.
Ligament, sir.
Very good. See, scapholiner ligament. See, unlike I keep on stressing about orthopedics is you just look at your hand, you will identify radial, ulnar, everything, then you will come to ulnar, certainly no, far away. Lunar triquetral is again on the ulnar side. What you is left with on radial side is radial collateral ligament is one possibility and a scapholunate is a possibility. Scapholunate is the correct answer. Okay. So by ruling out, you can answer most of the question. One more important thing is
Mary Thomas.
very good. So this fellow is one. I don't know. Of course, I've not watched any of his movies. He is one famous Hollywood star, Terry Thomas. Okay. There's a space between two incisors, which looks like that, which has been described in the past. Anyway, scapholunate dissociation. Terry Thomas sign is seen in scapholunate dissociation. Okay, remember that. You can answer this question. Most common nerve involvement in the dislocation of the lunate. Very, very easy. Quick. I'll have a timer next time.
Sir, medial nerve.
Very good. So, okay, sorry. Median nerve. Look at again as I'm saying, anterior and posterior interosseous nerve ends somewhere before the wrist. Before the wrist. Ulnar and median nerve. Ulnar is on the ulnar side and goes through the Guyon's canal. Median nerve, of course, just exactly in the center under the
Carpal tunnel, sir.
yes, very good. So this is one. I mean, just to make sure, as I was mentioning regarding carpal tunnel and the lunate, there is a dislocation here. It is compressing on the median nerve. Anyway, hand injuries. Which bone doesn't form the wrist? Yes.
Sir, ulnar.
Yes.
Sir, ulnar.
Allah, very good. Okay. Wrist joint is radiocarpal joint. Another name, carpal bones and radius. Ulna has no role here. So ulna forms only inferior radial nerve joint or superior radial nerve joint. Okay. Next, boxer's fracture.
Fifth metacarpal bone.
Very good. Very good. Fifth metacarpal bone fracture. One interesting thing I will tell you, because sometimes the questions are very, very tricky. Most common fracture in a boxer is a first metacarpal bone.
Sir.
Okay. Yes. No confusion here. Okay. Please remember, other students pay attention. Most common fracture in a boxer is first metacarpal.
First metacarpal.
But boxer's fracture is fifth metacarpal. It is some play of words in English, but you can always remember.
Yes, sir.
Okay, so this is a boxer's fracture. It is the neck of a fifth metacarpal bone. Neck of a fifth metacarpal bone. So you can see this is a old boxer's fracture. You can see the knuckles were prominent. The second, third, fourth, fifth is missing.
Yes, sir.
That's where it is a malunited fracture neck of metacarpal, fifth metacarpal. Okay, remember this. No knuckle sign is one of the indication for old boxer's fracture. Okay, one important thing. This is very very essential, even in hand surgery or whatever. I don't know in what way this will appear as an MCQ, but please remember, whenever you make a fist, all the fingers point towards the scaphoid. Whenever you are examining a hand which has been injured in the past, if there is a rotation, if one will be a twisted finger, huh? So to test if there is any malalignment, you make a fist, all the finger ends point towards the scaphoid. This is one important point I wanted to mention. I don't know if it has appeared in any MCQs. So what is Bennett fracture?
Yes, sir. Fracture at the base of fast metacarpal, sir, due to pull of muscle causing dislocation.
I will come to that. Yes. You please remember that's there is certain very interesting thing about
Intraarticular, sir.
it is an intra-articular fracture. Okay, intra-articular fracture of thumb. If numbering the metacarpal is difficult, you remember it is a thumb. Okay, Rolando's fracture.
Fast metacarpal.
Yes. So both Bennett and Rolando's fracture are intra-articular fracture and
But
metacarpal fracture. Remember this.
Ronaldo has no dislocation.
Yes, I will explain that little later. I mean, subsequently I will explain that. But no confusion. Both Bennett and Rolando is
Fast
base of
metacarpal.
first metacarpal. Okay. So this is what I want to show you. See here, Bennett's there is a fracture. This is staying as it is, but the entire thumb with the diaphysis is pulled backwards, pulled proximally. That is Bennett's. Look at the Rolando's. Rolando's, this is a Y-shaped fracture, but this there is no displacement of the diaphysis or the metacarpal. There is no displacement. There is no proximal migration of first metacarpal bone. Please remember this. That is Rolando. Again, Rolando can be T and Y. If the fracture it can be like this, or fracture can be like this. There are two types of Rolando, that is T or Y. It is just the geometry how it appears, but that is not so important. So what is important is Bennett's. It is only fracture here. This part stays as it is, but the entire metacarpal bone is pulled proximally. Why it so happens is there is attachment of abductor pollicis longus. You should remember this. Abductor pollicis longus. Move your thumb wherever you are sitting while reading. You move this abduction, you can feel. You abduct the thumb, you feel that at the base there is one tendon moving. That is abductor pollicis longus. Okay, this is what is being shown here. So this fragment stays as it is, but the entire thumb is pulled. So what happens in Rolando's? Even this part is fractured. So here this pulls only the fragment. The entire thumb is not pulled. So that's why there is no proximal migration of the first metacarpal. Is it clear?
Yes, sir.
Okay, good. So Bennett's fracture is
Fracture metacarpal.
very good. Metacarpophalangeal. Read once again.
No, sir. No, sorry, sir.
See, this is where you will know, but suddenly if you jump to answer impulsively, you will make mistakes.
Sir, trapezium metacarpal.
Yes. So instead of saying carpo metacarpal, trapezoid bone with metacarpal, isn't it? Which is the first carpo metacarpal joint. Okay. So
Sir.
impulsively don't answer, you'll be in a mess. Bennett's fracture is difficult to maintain in a reduced position, mainly because of pull of. We have explained that, isn't it?
Abductor polysystem.
Correct. So you can, that's what I was mentioning. Anatomical snuff box, look at your thumb. Abductor pollicis longus, you can feel as you are reading or going through the current presentation, you can feel that. Okay? Right. So gamekeeper's thumb. Gamekeeper's thumb or skier's thumb. Skiing is, you know what? Ice skiing. Gamekeeper's thumb. Can anybody answer this before going to literature? It will be interesting if somebody can answer.
Um,
Yes, anybody can take this. Okay. Anyway, the answer is ulnar collateral ligament injury of thumb MP joint or first. Now we have finished the carpometacarpal. We are going distally. Remember this. Then you will be easily now. At least now you can easily guess. Not every time. Okay. What happens? Look at this. Ice skiing. So what happens if there is a injury of there is a metacarpal with a phalangeal joint? It has ulnar and radial. Ulnar is on ulnar side, radial is on radial side. Ulnar carpal ligament, ulnar collateral ligament, and radial collateral, depending upon the position. So if there is a forced abduction, you can maneuver this sitting. Again, I'm repeating, you can maneuver your thumb sitting there wherever you are doing whatever you are doing. So if you try to twist the thumb on radial side, you see you apply pressure on the ulnar side, there is an injury to the ulnar collateral ligament. Injury to the ulnar collateral ligament is gamekeepers or skier's thumb. Look at this. I mean, this is the correct technique. Okay, fortunately, if you are going to Alps or Switzerland for ice skiing, remember how to wear this. This is a pole, what you use. You should use like this, not like that. Okay. Anyway, you don't have to remember this for exam. After you become postgraduate, you can go there. So gamekeeper's thumb is injury to the ulnar collateral ligament of metacarpophalangeal joint. First metacarpophalangeal joint. Okay. One more important thing is there. See what happens. You remember in gamekeeper's thumb or baseball's thumb, okay, remember gamekeeper's thumb. So there's something called as Steiner lesion. Okay, a lot of things to remember, but it is very logical and easy to remember. That's why I'm mentioning this. It might appear in one of the MCQs in upcoming exams. So this is the adductor pollicis. Adductor. Base of the thumb, abductor pollicis, isn't it? Base of the thumb, abductor pollicis. So in the first thumb space or web on the ulnar side, you have adductor pollicis. Okay. Once there is a rupture of the ulnar collateral ligament, there is some disturbance from somebody. Okay, watch it. So if this torn ulnar collateral ligament comes out of this aponeurosis of adductor pollicis, so it comes out, means it is not going to heal. Look at this diagram. So The collateral ligament is inside the adductor pollicis. If it is torn, suddenly it comes out and it stays here. So it is not going to heal. So thumb will become permanently unstable or dislocation is irreducible. Simply, to make it more simple, Steiner lesion is seen in gamekeeper thumb. Remember that, gamekeeper thumb, because of rupture of ulnar collateral ligament. Mallet finger, quick. Yes.
Sir, rupture of flexion is
Rupture of rupture
flexion
of. See, what is mallet? Mallet is hammer. Remember, mallet is hammer. So you take one finger and keep it flexed like this. So if it has to be kept in flexion position, what has to be avulsed? If distal phalanx has to be kept in flexion, loss of extension. Loss of extension is because of avulsion of the extensor tendon. Is it?
Yeah.
Yes or no?
Yes, sir.
Okay, I'll explain that in a picture later. Okay, see, mallet finger is the distal phalanx is in flexion, like you are drumming. It is a mallet is for use for drumming or hammering or whatever. Okay, if this has to be kept in flexion, there has to be avulsion of this distal phalanx. This part is avulsion, means there is a tendon which is attached here. If there can be rupture of this tendon, or there can be avulsion with a bony fragment. Okay, that is mallet finger. Look at this. This is very important diagram. Please remember this. First one is mallet finger. Second one is there is a
Swan neck.
flexion. There is a flexion of distal phalanx, but there is a hyperextension here. Looks like a swan, isn't it?
Yes,
But
sir.
here, this is normal. There is only flexion. This is a progression. Mallet finger, if not treated, it can become swan neck. We can discuss that later. But remember, this is a progression. Normal PIP. This is DIP. Okay. Hyperextension, swan neck. And buttonhole deformity. Buttonhole nothing but buttonhole deformity. Buttonhole or buttonhole deformity. Where
Rheumatoid.
here, okay, rheumatoid, it is seen in rheumatoid. Here, flexion is at a distal interphalangeal joint. Here, the flexion is at a proximal interphalangeal joint. You do this on your finger, then you will remember. Okay, or you can easily remember swan neck or opposite of the swan neck. Both are opposite. Okay. Jersey finger is caused by the rupture of what is jersey? Okay, there is silence everywhere.
So, traumatic rupture. Flexor digitorum profundus.
Yes. I hope you are not referring to Google there, sitting with the camera off. Okay, good. See, mallet finger opposite to jersey finger. Mallet is rupture on extensor tendon. Jersey is flexor tendon. Of course, there are two flexor tendons, flexor profundus, not superficialis, because profundus is attached to the tip base of the distal phalanx. I'll show
Yes.
some diagrams, then it will be easy to understand. See why it is called jersey finger is in playing football. If you try to pull you will be trying to pull your opponent by putting hand in his jersey. Jersey is a t-shirt. It's a
Yes.
uniform. Okay. So, but he'll escape. So suddenly there is a hyper extension. You have flexed it to hold his jersey, but he escapes, and there is a rupture of a flexor digitorum profundus. Okay, that is jersey finger.
Okay, sir.
Mallet finger and trigger finger. You just go through this chart. It is interesting, and I'll come to some questions little later. Mallet finger has been explained, isn't it? It is a distal interphalangeal joint involved. No need
Yeah,
of.
for
Huh? Yes.
sir, which ligament in mallet finger, sir?
No ligament. It is mallet means what happens? I told you, no. You forgot
Yes.
so quickly. Extensor tendon is ruptured.
Okay, sir.
Mallet, what I'm telling you, imagine you make your finger curl like that. Try to
Yes.
hammer the tip. So
He
what
can't
happens?
extend.
He can't extend means there is a rupture of extensor tendon, isn't
Yes.
it?
Yes, sir.
Okay. Trigger finger, I will come to that later. You don't want to get into this. Okay. No man's land in hand surgery. All are false except means which is true. Is it a difficult question?
No, no, sir.
Huh?
Sir.
Okay, no worry, no worry. It is apparently difficult, but of course, this is not something what I have been creating. These are something which have appeared in the past. Remember, these are not something. It might appear difficult because you have not read, but these are definitely questions which have appeared in the past. Comprises of the zone two is the true answer. Extends from if you read this they'll be confusing. I will show you a diagram so that you'll remember very easily. One thing you remember, why it is called no man's land. Why it is called no man's land is nobody wants to operate in if the flexor tendon injury is happening in that place. Nobody wants to operate means the results are not good. That's why it is called no man's land. No man's land in flexor tendons. Flexor tendons, there are different zones from zone 1 to zone 5. Zone 5 from distal to proximal. I'll show you some diagram, then you will easily remember. Okay. Zone 2 is no man's land. Please remember that. I'll come to that a little later. Okay. Yes. Remember this diagram. Very easy to remember. Okay, look at your hand and compare this hand. It is very easy. Okay, distal to the this part I was mentioning is a no man's land. If the tendons, flexor tendons are injured in this part, the results are very poor, less than 80%, even in best hand with the best microscope and best setup. The results are very poor here because there are two tendons, isn't it? FDS and FDP. They are closely approximated to each other. If you repair one, the other can be adherent to it, and there is an absence of smooth gliding. Smooth gliding is not there. That's why your finger movement will not be very nicely. It doesn't get a nice flexion. So Zone 2 is called as a no man's land. So one thing I want to mention, see this is carpal tunnel, remember. This is carpal tunnel. Carpal tunnel is beyond the wrist. Until I joined MS, I was still confused. But remember, here is your flexor retinaculum. Here is your pronator
Quadriceps.
sorry. Oh, sorry. Thank you for correcting me. This is pronator quadratus. This is your flexor retinaculum, carpal tunnel, all this. This is zone 5, 4. Beyond this is zone 5. Okay. So 4 and 5 easy to remember now. Remaining is 1, 2, and 3. This is important. Huh? I'm sure you might get some question about this. That's why I'm trying to make it appear very, very simple. So zone 1 is beyond the PIP joint. Beyond that is zone 1. Beyond, proximal to this is zone 2. Till where? Till where? Distal palmar crease. You flex your MP joint. You will know that is a distal. So this is 1, 2, 3.
Yes,
So
sir.
3. Please try and concentrate. It is nothing very, very difficult to make up, but you can easily remember. 1, 2, 3, 4, 5. Okay. If you imagine this picture, any question pertaining to this, it is very easy to answer. So results are poor in zone 2 and also zone 5, but zone 2 is called no man's land. Okay.
Yes, sir.
There are something about police. Okay, you have to remember this. I will not make it complicated. I'll try and make it very simple. You imagine there is a long thread tied to the finger. If you flex, it should become like a bowstring, isn't it? Bow and arrow. It doesn't become like that because there are so many pulleys trying to hold the tendon close to the bone. So these are the pulleys. So pulleys are two types, annular and cruciform. Annular, 5 pulleys are there. Cruciform, 2 pulleys are there. Annular pulleys are important. I will come to one or two questions about that little later. See, remember, annular pulleys A1 to A5. A1 to A5. They are nothing but, see, A1, 3, 5. Remember this. A1, 3, 5 are in front of the joints. A1 at metacarpophalangeal joint, A3 at PIP, A5 at DIP. Easy to
Okay.
remember?
Yes,
Five
sir.
five annular pulleys. A135 is corresponding to one joint. 3 joints are there in each finger. A135. So in between
Yes,
is
sir.
2 and 4. Very easy. So that ends your annular pulleys. What is remaining is cruciform. Cruciform. See, annular is like a ring. What you wear, isn't it? This is a ring. You are like a finger ring. Cruciform is cross. Cruciform is cross. So there are C1, C2, C3 pulleys. There's nothing much important about that. Of course, that is for postgraduates. I will not explain. But please remember these 5 annular pulleys. A1, A3, A5 is corresponding to the joint. In between is a 2 and 4. I'll come to that little later. They are important with respect to certain MCQs. That's why I'm telling you. So, decurrence disease classically involves,
No, sir.
yes, have you heard of this?
No, sir.
Okay. So it is tenderness, tenosynovitis or tendovaginitis, stenosing tendovaginitis of extends EPB and APL. I was talking of first extensor compartment, isn't it? I'll show you some diagram. I'll come to that little later. See, this was I was mentioning anatomical snuff box. Very easy to remember. The importance, as I said, is scaphoid bone fracture, autonomous zone for radial nerve, and scaphoid ligament injury. And important here, this part, if it is tender, it is decurrence disease. Decurrence is tenosynovitis here. There are two tendons. The lateral border of your anatomical snuff box. There is a retinaculum, extensor retinaculum. If it is thickened here, it is read about six extensor compartments. It is easy to remember. Decurrence is involves extensor EPB and APL. Extensor pollicis brevis and abductor pollicis longus. Finkelstein test is used in they're connected, isn't it? You can easily
Recurrence involves vaginitis.
decurrence. So this is what is a Finkelstein test. Flex the thumb and ulnar deviate. If it is tender, it means decurrence is positive. Decurrence disease. But you without thumb, you keep the thumb out of the fist and move ulnarwards. It is not painful. Thumb inside the fist and ulnarwards. If it is painful, it is a decurrence disease. Okay, trigger finger. I was mentioning in the past slide, but now it is appearing. Okay, what is trigger finger? Quick. Yes.
Sir,
Hmm.
Any of the above.
Any of the above. Okay. I'll come to that. See, one weird thing is injury to the finger while operating gun. This has nothing to do with the trigger. Okay, this is gone. If this is gone, this is also gone. So what is remaining? Feature of a carpal tunnel or stenosing tenovaginitis of a flexor tendon. Okay, you please remember two choices now. Then I'll come to explanation of that. I don't want to answer this now because you will not remember. So if you understand what is trigger finger, you will answer this. We'll come to that. Cause of trigger finger. Okay, and
trauma.
this trauma, repeated trauma is a trigger finger. Cause of trigger finger is thickening of flexor tendon sheath, local trauma, unaccustomed activity, any of the above.
Following local trauma.
Any of the above. Okay?
Sir.
Okay, I'm coming to the end. Before that, trigger finger, for that I will again go to this slide. This is a flexor tendon, isn't it? This is
Yes,
a
sir.
pulley. If there is a flexor tendon here, there's a long flexor tendon here, it is covered by a tendon sheath, isn't it? These pulleys are nothing but thickening of tendon sheath. Okay, this fibrous sheath is like a tunnel for a flexor tendon. Imagine a tunnel where train keeps moving. Okay, it is like a piston or a train going under the tunnel. The tunnel or the bridge is formed by this fibrous thickening of fibrous tissue. This tendon underneath glides easily, goes in and comes out easily. If there is a swelling here, or narrowing it, if the tunnel is like this and if the mouth of this tunnel is narrow, what happens? Your finger doesn't glide easily. So you want to extend, you keep doing with me there. You try and extend the fingers. It doesn't extend because this tendon doesn't allow to glide easily. There is a swelling, which there is a narrowing of this, and tendon gets stuck. So finger becomes flexion. Suddenly you have to use your other hand to make it straight. So you will hear a pop sound. It like a trigger of a rifle. You flex it, easily it comes. This goes out. There's swelling here because of the narrowing of this. There is a narrowing of the sheath and there is a nodule here. There is a discrepancy. It is like a bus filled with people sitting on top, and suddenly a tunnel comes. They have to duck, isn't it? Otherwise, it gets they get injured. So this swelling is there on the tendon. It doesn't allow to glide easily inside. So it gets stuck. So for that you have to you watch some video. I think it will be easy if for me to you to understand. Okay.
Okay, sir.
Okay. One important thing is this important pulley involved in trigger finger. Okay. I was mentioning A1, A3, A5. Okay.
Yes, sir.
A1, A3, A5. A1 is MCP, metacarpophalangeal, PIP, and DIP.
PIP.
Okay, which pulley is involved?
A1.
Which pulley do you think is involved?
A3, sir.
Huh?
A1.
A3.
Anybody?
A3, sir.
No, no, A3, no. For that, we'll go back again. See, what I was talking, this tendon doesn't get into the sheath easily. Where is this first pulley? This is the first pulley, isn't it? A1. A3 is here in PIP. A5 is in DIP. A1 is in MCP.
Yes, sir.
Okay, what you do if there is a mismatch? The swelling is big, the entry is narrow. It doesn't go in easily. So what we do? We have to release this. You make the opening wide, isn't it? So what you do? You release the A1 pulley. You can release the A1 pulley completely. So the swelling can glide easily from here till here. The swelling can glide here till here because we have removed this A1 pulley. Okay, right. By that I come to the end of this class.
Okay, sir.
Uh, Thank you for patient hearing.
Thank you,
So,
sir.
Shivanand, I
Yes, sir.
want to get some feedback from Shivanand, and one more guy is there. Who was that?
Sir, he left, sir.
He left. Okay.